Okay, good evening, everyone. I see we have a lot of attendees already. Um, I think we can do the introduction while all the others join so that we do not start too late. Thank you for joining tonight's session. We have the world-renowned rare disease expert, and we are very privileged to have him here as a speaker tonight, Professor Chris Hendriksz. I'm going to read a short bio of Prof. Hendriksz. Just as an introduction, Prof. Hendriksz is qualified as a medical doctor in South Africa in 1985 from the University of Pretoria, completing his master's degree in sports medicine at the same university, and then, due to a rare disease diagnosis of his own child, moved to the United Kingdom and continued his studies as an expert in inborn errors of metabolism at all ages by obtaining his MRCP and FRCPCH with subspecialty registration. He's an extraordinary professor at our Center for Human Metabolomics at the Northwich University of South Africa, and also an extraordinary professor of pediatrics and child health at the Steve Biko Academic Unit at the University of Pretoria. He was employed by Nestle Health Sciences as Global Clinical Development Lead for Rare Diseases, Inborn Errors of Metabolism, and Innovative Pharmaceuticals. It says, but will retire at the end of March 2024. So you are retired now. That's why you look so relaxed. He will continue his lifelong passion beyond this date, which relates to medical education and supporting rare disease service developments in low and middle income countries. He is currently a medical and strategic advisor for A Rare Cause, a non-profit organization based in England, which educate clinicians on rare disease management in more than 50 countries, and the list is growing yearly. This creates hope for those with least chance of being recognized, in his own words. He provides expert knowledge to patient organizations, foundations, regulators, and payers in his field of expertise. His publication list contains more than 250 publications, with the majority on lysosomal storage disorders, numerous ones related to clinical trials, quality of life, clinical guidelines, and review papers, as well as several book chapters in the field of inborn errors of metabolism. It's really, really, as I said, a big privilege to have you here tonight, Professor Hendriksz. Thank you for taking time to do this presentation with us, and thank you that you're continuing your legacy even after retirement. Just a few practical questions. We will have questions and answers just after the session, after the talk. You can type your questions in the Q&A function or in the chat function. And if you wish to, we can unmute you. You can just give me an indication and we can unmute you so that you can speak to Professor Hendriksz live. Thank you, Prof. Good luck, and we're looking forward to your presentation.
Good. No, thank you. It's my pleasure to be, and I always love sharing this passion of mine. And let me start setting up the screen. Let me quickly switch out. Hopefully, hopefully you can all see that now. And please feel free to let me know if you can't. It's a little bit one of these things when you're a little bit in the blind inside the presentation mode, you can't see everything. But I was given this topic, the value of collaborative clinical approach in rare disease education. And I thought, how do I tackle this? And I'm going to tell you, maybe not as you expected, but that would also be normal for me. So let me get into the first part of the presentation, if it will proceed. There we go. I think the first thing is whenever we do these presentations is that we do make sure we give our disclosures. So as said, I am a consultant for Filmca Medical Limited, which is a family-owned company. That company also has a charitable arm, which is called A Rare Cause, for which we do most of our work. And at the moment, as Ilse has just said, I have retired from clinical practice. So under UK law, I'm now described as a non-prescribing physician, but with full registration, which means I can give advice and support other clinicians, but I can't physically see patients on my own anymore, and which is a lovely position to be in because I can then share information. So, what are we going to be doing tonight? Firstly, what I'm going to do tonight, and my aims of this presentation, is that I want you to see a rare disease patient as an opportunity to acquire knowledge, but also to share knowledge. And I am going to give you quite a lot of examples and tell you a story. That's the way I do things. And what I would want you to do is to be honest. So towards the end, I'll put the slide back up for you. Is just tell me, have you learned anything new? Have you had nothing new? And that's okay, because frequently people don't learn anything new. Or if there are 0 to 5 new facts, or 5 to 20, or more than 20. And then once you've got the knowledge, what are you going to do with it? There's no point having knowledge and doing nothing with it. So this will come back again, and it's just to prime you. You can put this all in the chat, and it'll be useful for me to know what is your perceptions and how this goes forward. So let me start off with a few quotes, with a few quotes, which is that education is a progressive discovery of your own ignorance. You all know the saying that you will only find what you look for. So if you never consider a rare disease diagnosis, you will actually never find one. And then there is a frightening statistics, and I don't know which specialties we've got online, but there's been a little bit of work done that says the average pediatrician would have a lifespan of 25 years. In that 25 years, you will have 500 patients which potentially have fit into the category of a potential rare disease. And out of that 500, actually, you will have 30 confirmed. If you put that into, each and every pediatrician is likely to see 2 rare disease patients per year. And if you are not diagnosing 2 per year, you're missing 2 per year. The next challenge is the old-fashioned thing is that we know that in medical education, we always say there's the see one, do one, teach one, as Halstead described it. So when you see a rare disease patient, I believe it is your responsibility to make sure you then find another one, because usually you see one from somewhere else or in a presentation like this. And then once you found your patient, it's your responsibility to teach the next generation or the next doctor, because that way we expand the knowledge and we do a service to our patients. And of course, the African proverb is very well known, and this is very true for rare disease. If you want to go fast, go alone. But if you want to go far, go together. And rare disease management and education is all about going together, sharing what we have and sticking together and trying not to be on our own. Get people to work together. So let me start you out with a story. Now, this is a real life story. I do have the permission of the doctor to tell the story, but he has asked me not to mention the country just because they're in quite sensitive negotiations. So this is true life story, which happened a few years ago. We were reaching out to doctors in sub-Saharan Africa to attend one of our training meetings. And this doctor was on the list of contacts, and he got the invitation to a rare disease training session, which was going to be held in Botswana. And he looked at it and he thought, it sounds like an interesting thing. Maybe I'll go. Sounds very interesting. Anyhow, while he was considering it, one of his friends called him and said, he's really sorry, but his mom has become very ill and he needs to leave the neonatal unit. Would he mind looking after the neonatal unit just for a little while, that he can go and see his family? He'll be back within the next week, and then he will cover him to go to the training event. So we thought this is a great idea. And he went to the neonatal unit and they did the handover. And when they got to one little patient, his colleague said to him, this little baby in the corner, this is our Noah baby. He's unfortunately going to die. He's deeply jaundiced, he's multi-organ failure, and he's got meningitis. So there's not a lot that you can do for him, but please look after the family and do your best. And that was how he left him. And then, of course, this doctor said, but I'm going to rare disease training. Maybe I should read about neonatal disease and rare diseases. So we started reading about rare disease. And as he read through the stories and some of the things which is in the public domain, he said, oh, maybe I should look at this patient. Maybe this is a rare disease. So let's tell you a little bit more about our little patient, and I'll finish the story for you at the end. So firstly, this patient has got hyperbilirubinemia, so which means high bilirubin. Now, the first thing that is important is that when you look at the international data, that sub-Saharan Africa and South Asia has got the highest mortality and morbidity from high bilirubin in the world. More than a half of all the children who sustain some damage in the world due to high bilirubin lives in sub-Saharan Africa and South Asia. So there is a specific problem there. And of course, we know G6PD is one of the causes. But it's interestingly, when I looked at all the reviews, there is no mention of conjugated hyperbilirubinemia, also called cholestatic jaundice. So this is really just unconjugated hyperbilirubinemia, which is primarily rhesus disease, incompatible blood groups, together with causes G6PD, which is the commonest one. And the only mention of cholestatic jaundice in all the major reviews is this is potentially due to thyroid dysfunction and sepsis. Those are the only things mentioned. However, I kept on looking, and then I found a very recent South African Journal of Child Health review published at the end of February, so I'm not entirely sure if it's only online yet. And they did a review in South Africa, and they found that there is a 26% mortality of all cholestatic jaundice patients. That means 1 in every 4 patients in South Africa in the order to have cholestatic jaundice died. And the commonest cause was biliary atresia, for which we all know there is a surgical procedure. But the majority had neonatal hepatitis. But nobody has gone into what are the causes of neonatal hepatitis. And I'm going to talk to you about a little bit of one of these cases. Of course, you would expect me to, because our little patient, which I'm telling you about, had cholestatic jaundice, so which is conjugated hyperbilirubinemia. Now, there is biochemistry methods that you could do to see if this is conjugated hyperbilirubinemia. Of course, you look at the fractions between conjugated and unconjugated. But actually, there is a very easy method. And when you've got conjugated hyperbilirubinemia, you actually get pale stools. So sometimes it's just worth asking the family, what do the stools look like? Are they normal or are they pale? Now, they go through different phases as the jaundice improves. But once they've got complete conjugated hyperbilirubinemia, they've got these white putty stools, which is in the left corner. Now, if you're not somebody who likes looking at poop all the time, there is actually an app, and you could use your camera. It can show it at the poop, and it will tell you more or less where that fits in. And it's a useful tool to look for other causes of abnormalities in infant stools. So just a useful clue that you could use in some things, and I think it's just a really useful tool to use. But it also shows us that there are easy ways to actually find it out. So our little patient had got conjugated hyperbilirubinemia. Now, I always say to people that when you practice in medicine, unfortunately, you've got the legal teams always looking after your shoulders, and you always have to vindicate yourself. But I also use vindicate, and I'm not unique. There's lots of people in the world who uses this. Vindicate is used as a mnemonic for different causes for different disease. And I use vindicate for all of my diagnoses. So first thing to remember is that common things are common. You don't start off with uncommon things, but you start with common things. And then you start looking into different areas. Now, of course, I'm going to be concentrating here on the endocrine field in the red, metabolic, endocrine metabolic, because that's my specialty. But it doesn't stop me that when I find a patient that I'm not sure, I go through each and everything. And I've put this vindicate in a circle, because really what it is, you need to decide where you're going to start. And as I've said, you only find what you look for. So if you start off with this little baby and think he's got meningitis, you're going to start with infectious causes and start looking there. And if you can't figure out the infection, you do need to go to one of the other categories and work through systematically. Now, by pure serendipity, our doctor went from infectious to metabolic. And the only reason he went there is because he was invited for an educational event. That is medical serendipity. It means you do something that you not normally do, but you end up with the right answer. And sometimes it makes you famous, and it dramatically changes your career, which is the case here. But let me tell you a little bit more. So this patient high on my list of conjugated hyperbilirubinemia would be, of course, galactosemia. So for those of you who don't know, basically this is lactose, which gets broken down into galactose and glucose. And the enzyme involved is the GALT enzyme. There are different types of galactosemia. I'm not going to concentrate on the other types. I'm talking about classical galactosemia because that's the commonest form, which is GALT. And what I explain usually to families and people is that when you look at rare disease, an enzyme deficiency is like a pair of scissors. So you've got a big molecule here, which is lactose, and your chemical scissors or your enzyme will chop that into galactose and glucose. So you know what are the byproducts of your disease. And once you know the byproducts, you could potentially start changing that to some extent. So we also know that, of course, lactose comes from milk and cheese, but also remember, fruit and vegetables and medication also contains lactose. And that lactose gets broken down to glucose and galactose. And of course, galactosemia, it's the galactose, which is the component which causes the damage. But the negative side is we also make galactose. So you can't make a patient galactose-free. There will always be endogenous galactose production. And that level of production depends on the mutation. So depending on your mutation, the amount of galactose will actually be there. Now, the galactose is the toxic metabolite. And I won't spend time on it at the moment, but actually there is an indigenous galactosemia mutation, which is very common in our indigenous population in Africa. And that mutation actually makes a relatively small amount of galactose, which means if you catch them as a neonate and they survive, their outcomes are actually a lot better than the classical galactosemics, which we see with the European mutations. And we'll touch a little bit more. So, but what I thought I would do is I'm going to show to you firstly, what does classical galactosemia look like? And then once we know what it looks like, I'm going to take you through each and every one of these things and tell you which specialist is likely to be called in or touch on it. Now, of course, this depends on geography. Some countries have got different healthcare systems. I've looked at the most complex, which is the kind of European system. We've got much more people in it, but you can easily replace them and see where is the opportunities for both learning and also for working together. So classical galactosemic patient starts off with poor feeding, lethargy, diarrhea, conjugated hyperbilirubinemia, hypoglycemia, which in our little patient was said to be due to the liver failure, but it is a cause. Classically, they get E. coli sepsis, and I'll talk through all of these with you. They get cataracts, they get developmental delay, speech disorder, but then as they become young adults, they've got puberty failure, ovarian failure together with an adult learning disability. So this is what classical galactosemia looks like, but it's a journey through a whole lifespan. So let's start going through our little baby, which I'm going to keep on telling the story all the way through this presentation. So firstly, this baby has got poor feeding and lethargy. So the first person who may actually cotton onto this is the nursery nurse. So the one looking after the moms and making sure they are feeding the babies and all is going well. But also you may find the parents, because they may have had a child with a similar condition. So they may say to you, this baby is the same than my previous baby who was just as sick and died. And that could be a really early clue for you to ask, but what disease that they have, or if they didn't find it, which additional tests can you do? Which of the vindicate elements that they not look at? Of course, the nurse in charge potentially could get it, or you could find the neonatologist, because the neonatologist, when you've got a baby who's poorly feeding, you would always think about sepsis. And of course, in our baby, there was sepsis, and actually the baby had meningitis, but he had E. coli meningitis. Now, another fascinating fact is that you may not know is that E. coli uses galactose as its source of feeding. It proliferates magnificently. So when you see florid E. coli infection in a neonate, there's usually a lot of additional galactose coming into the system. So with galactosemia, we see this E. coli sepsis very classically. So that should be another thing. So if you are the microbiologist being involved in looking at cultures, the moment you see the E. coli sepsis, you should be thinking, should I put a little note on there? Have you considered galactosemia or other causes of high galactose in this patient? Or you may be the infectious disease or the immunologist being asked, why does this baby have such severe infection? Only in a few, this baby was only about 2 weeks old when the handover happened. Why is it so severely ill at such a young age? Does it have an immune deficiency? But again, if you're aware about it, you should remember that. But then if you've got a young baby with severe diarrhea, early onset diarrhea, you could also use this as an opportunity to teach. There is a condition called congenital chloride diarrhea, ultra rare condition, but very good outcome if you treat it early and found. So you could use this and also say, actually, there are other causes of diarrhea, but you can expand it. So you can also say, when you have an older child who's got developmental delay and chronic diarrhea, we say you need to look at conditions like Sanfilippo, because these are conditions where the chemicals accumulate in the gut and which causes the diarrhea in these children. So you can see we started off with a baby with potential galactosemia, but we're already starting to touch on 2 additional rare disorders just from the first amount of information we're looking at. When we move into the next slide, you will see this baby had conjugated hyperbilirubinemia, as I've said, or cholestatic jaundice is the other name, and also hyperglycemia. So again, your neonatologist could become involved, and here also, or a community pediatrician, the baby may have gone home already, may have become sick only once it's gone home, or a community worker, or the hepatologist may be called in because the baby's now in liver failure. Endocrinology may be involved as the hyperglycemia, or you may be sitting in a laboratory and you see these results coming through. You see a child on the results with conjugated hyperbilirubinemia and hyperglycemia who's very ill. And is it worthwhile putting the note on or ringing the unit and say, listen, guys, I know this is very rare, but if everything else has been excluded, have you thought about a rare condition like galactosemia? But also there are other causes of conjugated hyperbilirubinemia, which we find which are rare diseases. So you've got all the bile salt defects. These are known as bilous disease and ATP69. There's different names for them, but there's a lot of transport defects causing this as well. There's also biliary atresia, which of course there's surgical procedure, or you can have a choledochal cyst. Simple ultrasound of the liver will show a choledochal cyst. You fix it and you save the patient's life. So again, the rare disease is helping the commonest causes to be excluded and to be supporting them. When we start looking at hyperglycemia, of course, sepsis and everything causes hyperglycemia. But there are also rare disorders like fatty acid oxidation defects. These present really early in life with severe liver failure, low blood sugars, and also a cardiomyopathy. So you can bring another element in and say, actually, we need to think about more things, but this baby hasn't got anything of these. So we can to some extent exclude these diagnoses as well, just from knowing the good history. Moving on, you do develop cataracts when you've got galactosemia. It takes about 6 weeks for the cataracts to develop. So it's not quickly, it takes about 6 weeks. But again, if you've got a child who's conjugated hyperbilirubinemia, it's got cataracts, maybe you should think about it. There is also a different variant of galactosemia called galactokinase deficiency. They only have cataracts. And if you actually diagnose them early, you can prevent the cataracts, prevent them having cataract extraction, and protect their vision. So again, there are different ways you can do, but also it may be the optician which sees the baby first. And this gives you another opportunity. There are multiple ocular features of rare disease. Cataracts is one, but you could also have corneal clouding. We see in the mucopolysaccharidosis disorders, you've got corneal clouding. Or you get the classical copper rings of Kaiser-Fleischer, which we talk about, which is Wilson's disease, so which you can see as well in the eyes. Or when you go into the adult population, if there are adult people on, you can see sunflower cataracts. Now, this is classically seen in amiodarone treatment. That's the common cause, but the rare cause is Fabry disease. So you can see how you could use this child and this child's condition when you engage with the ophthalmologist, you can share with him not only this case, but additional things. And that may help uncover the next patient. And that's the way you build your rare disease pool. And we make sure we serve our patients best and we're not missing treatable conditions. So when I say developmental delay, I think we all sigh, because the list of developmental delay is incredibly long together with speech disorder. But actually what is important is that when you've got a child with developmental delay and speech is part of it, you usually have a community pediatrician or a community worker, speech and language therapist, occupational therapist, dietitian. There's lots of people involved. And what your role here is just to make them aware that there are rare diseases which causes this. And busy clinicians may not have thought about it. So there is absolutely nothing wrong with a community worker or a speech and language therapist writing a little note to the doctor and say, listen, I've seen this child. You know, this child has got speech problem. Mom has told me they had a similar baby. The baby died with jaundice, had liver failure and things. Have you ever thought about maybe galactosemia? Because we know the earlier we treat these patients, the better their outcomes are. The next thing that happens to these little children is they can grow older. And as they grow older, they get ovarian failure. But here is one of the other things which is very interesting. Our indigenous African mutation of galactosemia, they don't develop ovarian failure, so they don't have delayed puberty, they don't get the short stature, and they don't get all the other problems associated with it, but they are subfertile. So they're not infertile, subfertile. So their fertility is not brilliant, but they can conceive, but they usually need some help. So they may end up, as they grow older, with the endocrinologist because of delayed puberty or because of growth failure, or with a pediatrician, or they may go straight into gynecology clinic, either because of delayed puberty, growth failure, or infertility. But when I say delayed puberty, growth failure, it immediately brings me to short stature. So what are the causes of short stature that you could bring in here? You could say there are skeletal causes, achondroplasia, which is one of the common causes. You can say there are more rarer causes like the MPS disorders, but also some of our dietetic conditions, glycogen storage disease, because of the severe demand on the metabolic rate. These patients get short stature as well. So again, you can see there are multiple causes. And this one patient of ours is opening so many little doors of opportunities of either the patient is going to need them or you can educate them, because this patient is definitely going to need some of these services. And as I promised, I will complete the story. So patients with galactosemia which survive early childhood get into adulthood, and depending on the mutation, it is very variable. I have galactosemia patients who's got master's degree, university degrees. I also have galactosemic patients who cannot live independently, who's got the very severe homozygous mutation, which we call the Q188R, which is the European mutation, which has got quite significant developmental delay and adult learning disability. So they really need support lifelong, and they will need neurology input. They're also prone to develop herniation of the cerebellum and the brain stem, so they can get an acute decompensation. Again, it's one of the things we think is related to accumulation of galactosemia, changing the osmotic balance, but they do need rehabilitation and support. So, but you see, we also know that this earlier you treat them and the more supporting services you bring in, the less the need is for the services as an adult, and the better the chances are that they could be independent, contributing to society, and not be a burden in society. So you can see how this whole picture keeps on breaking out further and further and changing what we see. But as I've promised you, we really need to finish the story, and I need to tell you the story of this. So this doctor which we invited, he had a look at this baby, and the first condition he ended up was galactosemia, because it is one of the commonest rare causes of conjugated hyperbilirubinemia. And in the country he was, there was no testing. He had a quick look and he saw there's a test called the Beutler test, which could be done, but it wasn't available. He then went and he asked he read a little bit more and he saw, but actually, this is a contraindication, one of the very few contraindications for breastfeeding. So he basically said to the nurses on the unit, listen, we're going to stop the breastfeeding. We know the baby's dying and the mom says she wants to keep on giving breast milk in the NG tube because it keeps it comfortable, but we're going to put him on a lactose-free diet. And we're going to do this for 72 hours. And if there's no change, we will continue with the palliative care. And of course, as you would expect, as soon as the lactose was taken out of the diet, the baby started improving within about 48 hours. The baby was significantly better. Liver failure started improving. General baby's condition improved. They got the galactosemia of the E. coli infection under control. And slowly but surely, the baby made a much better recovery. And they sent samples out with the help of the systems we've set up to get the official testing later on. And we actually confirmed the diagnosis of classical galactosemia, but of the African variant. So this is a child that potentially would have died, but has actually now gone on and is having a relatively normal early childhood. It had sustained some damage because of the severe liver failure and the problems it had, but is making really good progress. But the other thing that has happened in that country, the neonatal unit, they now routinely ask the nurses and everybody to ask, is there white stools? And what one of the doctors said, we asked them, does the poop looks like putty? That's one of the things they ask, because then they know it's conjugated to hyperbilirubinemia. They've also invested in getting a Beutler kit now. It's a relatively long test, takes about 4 hours, but it's a relatively easy test to do. And they now screen all of their babies with conjugated hyperbilirubinemia with a Beutler test because they know they can have a fantastic outcome. They also have used this patient to start building for other causes of conjugated hyperbilirubinemia in the neonatal unit. So they started looking at potentially finding children with tyrosinemia, and they've also started looking for patients with hereditary fructose intolerance and some of the other rare conditions. So they're starting to build a whole policy, at least in the neonatal unit, and starting to educate their colleagues, as I've told you, wider off where may they be seeing galactosemia and where does galactosemia features overlap with other rare diseases, thereby increasing the awareness of rare diseases in general. So this is my story that I wanted to share with you today. And what I wanted to just show you how things can make a difference. I will put it all together now that we say the treatment for these patients are lactose-free diet. Do remember, this is one of the conditions where breastfeeding is contraindicated. Very important, very difficult in Africa because of the situations around it. But all of these soya-based milks are safe to use. You don't have to use complex and expensive ones. They are more expensive than breastfeeding, definitely, but you can get a child with a normal outcome with soya-based proteins. So you will need a dietitian to help you sort out how to limit lactose in these patients. They don't need to be on complete lactose-free diet as adults, but definitely in early infancy, because the E. coli infection and the liver failure is driven by the galactose when they're young. Then you need somebody who actually coordinates the care. Somebody who says, I'm going to follow this patient through and hand it over to the next generation. Now, this may be an adult service of some sort once the child grows up, but they need to be made aware of these problems because this patient is potentially going to need puberty induction and lifelong replacement by hormone replacement to actually get normal sexual characteristics. So it will need further input. It will potentially need speech and language support, school support. The better the support early, the lower the burden of disease later on. As I've said, endocrinology really important, but also will need somebody to look after bone health. Because if you are on a lactose-free diet, your calcium intake is poor, and generally your vitamin D intake is poor as well. So really aggressive bone health management is needed, and this can be done by anybody. It doesn't need to be a specialist. And the other thing as well is, of course, you need to get the counseling in place. You need to start thinking when they get to puberty type age, to start talking about the potential of infertility or subfertility. You need to talk about their expectations. Parents may think they will be absolutely brilliant at going to university, but if they've got a severe mutation, that may be unrealistic, and it may be worthwhile talking through. And it's worthwhile talking about the other pregnancies and see how you can manage it. But the other thing is, we need multiple people to support these patients. But actually, the message I want to give you is that not all rare disease is expensive. We've calculated it out. And of course, it's more expensive than breastfeeding and everything. But you would be looking at the equivalent of about $20 is the treatment of this child per year. So not all the rare disease is expensive. So the excuse, we are not looking for rare disease because they're all expensive, does not hold water for me. You really need to be looking for these patients. And if these patients has got the African mutation, you catch them normal and early, you're looking at excellent, excellent outcomes for these patients. And it's really important when we do the hard work and try and find all of these patients. So I will summarize my case, which I say, what is the impact of one? One rare disease patient will have had 18 professionals who could have made the diagnosis. I've given you the list of those 18 people who could have been any one of them. If they've heard about galactosemia, may have turned this life around. We were lucky, in my case, our doctor was invited to an educational event, which got his eyes open to but everybody else has missed him. He's been in contact with many others. The earlier you make the diagnosis, the better the outcome is. And one patient will need multiple experts to achieve their full potential. But don't see this as a financial burden. See this as an investment, because a patient who's well supported has then got their own job, has got their own family and support structures, costs a lot less as a learning disabled person who needs to be supported long-term and lifelong. And there are multiple topics, but I've just pulled out here that one patient would have created at least 8 different large topics for educational opportunities. So we're all very busy, and I know that. But please do think, how can you help others with what you've learned? Don't keep your knowledge for yourself. Remember what I've said at the beginning. You are only changing your own perspective. Some of you may have seen I posted it this morning. Remember, knowledge and education changes a mirror into a window. It changes looking at yourself and your own problems to a window of what are the opportunities? What can I change going forward? So my question to you is, what is holding you back to be involved in at least one of these opportunities? What expertise have you got that you can help build this rare disease out? Because as you see here from Mission Cure, the statement they've made is, when you have a rare disease, you face 2 battles. One is the illness itself. The other is living in a world where so few people understand what you're up against. And I need all of you to be part of that team to fight for what you're up against. And what I'm going to do now, I'm going to give you a few seconds just to put in a little bit of the my final slide that I asked you. Have you learned nothing new? And like I said, I'm very happy that you say, no, I haven't learned anything new. Or a few facts. What have you done? How many have you put in there? But what are you going to do with these facts? And if you do nothing else, sign the INWEB pledge. The INWEB pledge and the program that we're working on is to get people to share knowledge and to work for the better good of all the patients. You all on this call have something to offer. My question to you is, what are you going to do with it? And how are you going to make a change? And that is my last slide. I'll keep it there, but I'm very happy to start looking at some questions if there are any.
Thank you. I just want to say thank you first. I think every time I listen to a talk that you give, I'm a bit speechless at the end. Feels like I I'm just brought back to the real life, you know, especially for many of us working in the laboratory and doing research most of the days. It's needed for us to, you know, understand the impact of what we do every now and then. So thank you. We've sent out a poll for you to answer. The poll is there. Prof, I don't know if you can see the poll.
Stop sharing. I don't see it, but like I said, it's more what I'm hoping is that we will energize people to show that everybody has got a role to play, and people don't always see what their roles are.
So we send out a poll and we ask that question: how many new facts have you learned from this talk? There's 0% who voted none. 27% voted 0 to 5 facts. 18% voted 5 to 10. 29% 10 to 20 facts, and then 21% voted more than 20. I see a few people are still voting, but it looks similar. So most people were between 0 and 5 new facts, and 10 to 20 new facts, more than 20. Absolutely no one said that they learned nothing. And I think that's a brilliant response.
It's also brilliant that you've got a basis. You already have a basis of knowledge. And that's why I say use it.
Yes. So if there's any questions, please type it in the Q&A or in the chat. I know I have a question that I've been wondering to ask. So I'm going to start with my own question then. So there is a question. Okay, I'm going to ask this question from Tumelo Satege because it's literally the same question that I had. Okay. So Tumelo says, thank you for the insightful talk on the important inborn metabolic defect in our setting. Is galactosemia due to African variant still referred to as the clinical variant, with the expectation of milder disease due to residual enzyme, or indigenous patients tend to have severe disease with undetectable GALT activity? And I think my question leads to that, because I wanted to ask, for the different variants and the different mutations, do we pick up all of those mutations in newborn screening, doing the enzyme analysis, or do we miss some? And what is your feeling about after the diagnosis to do genetic testing to confirm the variant? I know in Africa it's difficult.
Yeah, oh, absolutely. And like I say, it's a technical question. The first one that people tend to confuse is there is also something called Duarte galactosemia. So that is not real galactosemia. And some people think when we talk about the indigenous African mutation, we are talking about Duarte. Duarte is not. Duarte is a non-disease. These are people who's got a little bit of inactivity of the enzyme, but they've got no clinical features at all, which is different. So when you look at the classical galactosemia, you've got a breakdown of different mutations. Now, Q188R is the most severe common European mutation which we see, and that gives the very severe disease. But there is, and I can't remember off the top of my head now what the African mutation number is, but there is a big group doing more research on that, because we found that they do have some residual enzyme activity, which means that actually they've got a milder form of the disease. Now, I think many of those are walking inside the African community. They may have had jaundice, but not severe enough to end up in a neonatal unit or something. They may have cleared their jaundice, and they may end up being subfertility. It's quite variable on that one. If it's a homozygous mutation, of course, it's different to when it's a compound heterozygote mutation. So yes, it is. And from that perspective, I think it is generally, in the beginning, it's useful to do genetics just to see what is the mutations you actually see in your population. We don't routinely do full genome sequencing on things in our galactosemia patients. What we tend to do is we look for we've got a panel with about 10 mutations, and we only look for those 10, because for those 10, we've got the phenotype quite nicely packed out, and we know what to predict for the families. So which is what we do. But I don't think it's essential. I think the testing that we have is sufficient. I think the most important thing is to just make sure you've got the diagnosis spot on. And of course, then there is also the very rare form of galactosemia, the UDP GALT deficiency, which is a very different disorder. You could usually find them different because they've got some galactose activity. So you can find some enzyme activity, but it's the epimerase enzyme which is abnormal in them. So you have to do extended testing. So when you've got a classical patient, it's most probably less needed to do the mutations. It's when you've got one of these variants, I think it's much more important to see if you can actually get it. So I hope that gets it out, and I'm very happy to follow up and send people the mutation data and things like it. I can't, like I say, for the life of me, or somebody can Google it quickly. It's called the sub-Saharan African mutation for galactosemia, which is well described, and it's the biggest difference is that actually they don't have infertility and growth failure. They tend to have normal growth and subfertility. Then the other thing, just interesting on the mouse model, and it may be that's some of the work being done at the moment, is the difference with the African mutation primarily due to enzyme activity, or is it due to a modifier gene? So when we made the first galactosemia mouse model, it did not have the phenotype. So although you can do a complete knockout, it did not have the same phenotype than the human. However, when you knock out one of the oncogenes, it expresses the classical phenotype, which the group in Salt Lake City have done. So which does tell you that there are definitely a modifier gene involved in galactosemia. And that's why there's so much research at the moment on the African mutation, because people are trying to think there may be an oncogene which could be utilized. Are they protected? So are our galactosemic patients protected from some cancers because of the oncogene? And this is all things to keep an eye on. And I know there's a fairly big study ongoing at the moment, people looking for additional patients, which has got the classical African mutation, but not the classical European mutation. Hopefully that answers it, but happy to expand.
Yes, that certainly answered my question. To Melu, if you need a follow-up, please just give an indication. You could also put up your hand if you want me to unmute you. So my question is also, do we see these people in newborn screening? Do we see these African patients in newborn screening? And what's the prevalence, or do we actually have no clue what the prevalence is because we are not really testing for it?
Absolutely, we've got no clue. And that's why I say I was so disappointed when I saw the audit, which was published this year. Now, it's only an abstract, and I'm hoping that when the full paper comes out, there is some data on galactosemia, but I find it quite disappointing that it says most of the patients have neonatal hepatitis, because that is most likely there will be some galactosemia patients in there, and those are treatable patients. So no, we don't all catch them, which is why nobody is routinely screening for galactosemia in the newborn screening. Unfortunately, the old-fashioned testing where we did urine for reducing substances, of course, you will pick up your galactose in there as well, but nobody seems to be doing that anymore. But we do find in some of the other countries, or the poorer countries, that's what they still do. So at least you can pick up your galactose in your HPLC when you run. So that is a useful way to look for it as well. The only thing to remember is that there is a difference between galactosemia and galactosuria. And one of the other conditions which is starting to climb out now is citrullinemia type 2, which is also called citrin deficiency. Now, traditionally, this was thought is a disease of Asian people only, but actually we're finding multiple in all populations now. And they've got galactosuria, which clears after a few weeks. They've got galactosuria for about 2 weeks, then it clears, and those patients only come back as adults with acute liver failure, and most of them die.
I see we have another question. This is very intriguing to me. So I'm listening. We have a from Gillian Riordan. Sorry if I pronounce your name incorrectly. saying thanks very much for the presentation. I would just like to remind everyone to think of mitochondrial disease MPV 17 in newborns with neonatal hepatitis in sub-Saharan Africa. Sadly, no treatment as yet, but a diagnosis does help. Genetic testing is available from NHLS ChemPath UCT. So Gillian, I see you have your hand up and we unmuted you. I'll give you a chance now. I just want to see. Okay. Don't think my mic works. Okay. But anyway, so just a reminder to also think about, sorry, MPV 70 in newborns.
Just add there, Julian. Thank you for making that comment, because actually it's a really important, because MPV 17 is most probably very prevalent in our African population as well, and underdiagnosed and underthought for. So it really is an important one. And there is a whole group of neonatal hepatitis mitochondrial disorders in that group, DGOC and a few of the others as well, which is definitely worth looking at. And they can either represent with conjugated hyperbilirubinemia, unconjugated hyperbilirubinemia, and liver failure, or just the hepatitis picture. So they're quite variable, and it's a really important one. And it's really important we start building actually the picture of what are the common causes in these neonatal hepatitis cases.
Gillian is saying we have more than 60 patients since 2015 at the NHLS at UCT. Okay, Brenda is also saying what I was thinking of. You just mentioned that galactosemia isn't part of many newborn screening programs, but it is part of the CHM's newborn screening program. And Brenda is also saying that an article was just published with Helen Malherbe showing the galactosemia cases in South Africa up to now. So it would be worthwhile to share that with all the audience members. I don't have the link now. So yes, so galactosemia is part of the screening program at the Northwich University that we do, but we are not screening enough newborns. I think that's the biggest problem. We need to be able to screen more newborns on a regular basis from all areas, and we are really advocating for that currently. I see Prof. Chris has left the building. There he's joining again. Here we go. Okay, I don't see any other questions. I don't know, Prof, if you have any closing remarks. I'm trying to get the link for that paper, and I will post the link to the paper in the chat for everyone.
Absolutely. No. Hopefully you can hear me. No, my final words is just sign the INWE pledge if you haven't done it. Let's work together. Let's see what we can do together. And I love the comments which are all coming in here on the side, because we really need to start building a way and tackle this whole issue that we don't miss patients which is treatable. And especially from the lab point, if we've got some patient with a classical African mutations and things, if we could potentially get some samples to run on that MBS program to see, do we get them, and also to look at the specific patients we do have, although I know Brenda's put in there. I don't know if we've got genetics on them. It'd be really interesting to know, are there any with the African mutation in that group or not? Because if there's not, we may be missing them. And like I say, they tend to be from the indigenous Black population, which we've seen them. I've never seen them in a Caucasian patient. So again, there is worthwhile looking more into that.
So a final word from me is just that we have a rare disease biobank as well at the CHM. So if you're interested in also doing research on these types of cases, please contact us through the email, through our website, the National Metabolomics Platform. There's contact forms there, you know, because this is a brilliant idea, trying to find those galactosemia patients that we diagnosed and try to do some genetic testing on it to identify the specific mutations. That would be a very interesting research topic. So please please go to, there's 2 websites that I want everybody to look at tonight or whenever you get time. That's the website of the National Metabolomics Platform, and that's there you'll get more information on newborn screening, the biobank, and all the tests that we do. And then also have a look at the Hungwe website that Prof. Chris mentioned as well. On the Hungwe website, you will learn more about this initiative and our aim to work together in South Africa to get undiagnosed patients a diagnosis. Thank you everyone for joining. I don't see any further hands, but this was a very, very good presentation and a very nice talk afterwards. Okay, so we're being asked for some, I'm just going to take 5 more minutes. We have 2 more minutes, and I'm going to paste the links to those websites for you in the chat as well. It's hungwe.org.za. That's the one.
While you're posting those, it's one of the things I really would want us to do in South Africa, is to look at the galactosemia population, because I think it will also take the emphasis away for everybody saying that pulmonary disease is expensive. This is a cheap condition to treat, but the dramatic outcomes if you find them early.
Yes. Yes, exactly. So we've seen many times that they say that the prevalence is so low and there's no one with this specific disease, but there's no one diagnosing it. So when you start diagnosing it, it's then when you see that there is actually a lot of these patients around. Okay, I've pasted the information on the paper that Brenda mentioned. Thank you, Brenda. Also, so it's a link to download the PDF. There's a link to the Hungwe website and the National Metabolomics Platform website. May I please ask if you have any further questions or you need any more information, you're welcome to send us an email, or if you don't have the contact details or you're struggling to contact us through the websites, you're welcome to go to LinkedIn and leave a message there. We have a LinkedIn for National Metabolomics Platform and Hungwe. You can also contact Prof. Chris Hendriksz directly. I know you added your email address in the initial slides, but we can also share this recording with you, and then you will also have all the necessary information. Thank you, everyone, again for joining this late on a Wednesday. I wish you all a very nice evening further. Yes, and let's go and save some lives. This is your call now. Thank you, everyone, and enjoy the rest of your evening.